Hi there, and welcome back to the Dutch Podcast. I'm Dr. Jacqueline Smeaton, and on this podcast, we dive into the vast and ever-evolving world of hormones as part of our lifelong pursuit of better health. Here at Dutch, we've dedicated over a decade to transforming lives by addressing hormonal imbalances like cycle irregularities, perimenopause, menopause, and more. Our mission is clear: to simplify and advance hormonal health for everyone. On this podcast, I get to bring you cutting-edge insights from our top experts on hormone therapy, menopause, personalized medicine, and more. We're all aimed at making a real difference in your well-being. Your questions and feedback are crucial. They shape our discussions and help us navigate the complexities of hormone health together. Now, as always, please remember the content of this podcast is for educational and informational purposes only, should not be considered medical advice. Be sure to consult your healthcare provider for medical advice, diagnosis, and treatment. I'm really excited about today's episode. I think you are going to be too. We get so many questions at Dutch about different patterns that we see on Dutch testing. And today I get to talk with one of the doctors on our team about a pattern we see often, which is low estrogens. Now, when we think about low estrogens, we think about menopause. And of course, this is something we see all the time in postmenopausal females, but it also can show up on Dutch tests for cycling females as well as perimenopausal females. So today we're going to talk about why you might see that, what it means, and most importantly, how you can address it for your clients and patients. My guest today is Dr. Allison Smith. She's a naturopathic physician who completed her education at National University of Natural Medicine in Portland, Oregon. She's worked in a private practice focusing on primary care, women's health, and dermatologic laser therapy. Over the last 10 years, she's really honed in on her hormone expertise. She's consulted with providers on thousands of cases in the context of hormone testing and brought awareness of testing to providers in clinical practice through consulting, webinars, case presentations, and articles. She now leads our esteemed lineup of clinical educators at Precision Analytical, home of the Dutch test, and I'm really excited to talk with her today. Welcome, Dr. Allison Smith. So I'm really excited to have you here today, Dr. Allison, because we see all these different patterns on the Dutch test that come up a lot, and it can be great to sit with a member of our team and really break it down. And that's what I'm hoping to do with you today, is to break down that pattern we see with low estrogen. So I want to start by talking about low estrogen in a cycling female, because of course that's when we should be making more. We know that in perimenopause and postmenopause it goes down. We'll get there. But let's start with cycling females. What are some of the reasons why estrogen might be low in a cycling female?
Yeah, I would say, in somebody who is young and healthy, the most common reason we'll see low estrogen is in patients who are working out a little too hard, not quite eating enough, and we get some hypothalamic kind of suppression that can lead to low estrogen levels. It can affect egg quality over time and lead to low estrogens. Certainly not permanently. Often we can figure out what's going on. Cycles become irregular. It sends you to the doctor. We're able to kind of figure these things out, pretty quickly. But, if it goes unchecked for a long enough time, it can put people into like an earlier menopause. So we do like to identify these things early on if we can. But that's a pretty common one. Other reasons could be, genetic. Some people have just less body fat, so they make less estrogen total overall. But I would say that ovarian output of estradiol really depends on those hypothalamic and pituitary signals making it to the ovary and stimulating those eggs to mature and the follicles to develop.
Awesome. So let's step it back and break it down a little bit, because now that I'm hearing you explain this, I'm realizing some people might want a little bit more of a primer on estrogen as well. So can you tell me, in a cycling female, where is estrogen made and how is it made? Like, what are the signals that drive it to be made and why?
Yeah, good question. So when we're born with lots and lots and lots of little eggs in our ovaries, and those eggs are housed inside of follicles, little houses for the eggs. And when we are having we cycle 12 times a year theoretically, or sometimes a little more, sometimes a little bit less. But the idea is we have all of these chances to procreate, essentially. And we have a complex signaling system from the brain that starts at the hypothalamus. So it's the very center of the brain, this little tiny organ that puts out a gonadotropin releasing hormone that says, hey, let's develop a follicle. And then the pituitary catches that signal and upregulates what we call FSH and LH, which is a follicle stimulating hormone and a luteinizing hormone. And those signals enter the bloodstream, interact with the ovaries, and then we get some development of follicles and eggs, the cumulocyte oocyte cumulus oocyte complex, the COC. And together, the follicle and that COC start to develop. And we actually develop a number of them every month. And there's one winner. Sometimes there's two winners or three winners. Mm-hmm. Usually there's one winner, and that becomes the primary follicle. And that primary follicle starts making an awful lot of estrogen. And that happens during the follicular phase of every monthly cycle. So every monthly cycle during the follicular phase, we are estrogen dominant because those follicles make lots and lots of estrogen to fuel their own growth. And that really is kind of the business end of what we're talking about today, I think, is how estrogen affects growth and proliferation. And when we don't have it, what happens in the body. So in the follicular phase, we're estrogen dominant. That signal to the brain tells us that it's time to ovulate. We get the LH pulse that tells us, let's go. And once we ovulate and that egg leaves the safe little follicle building and enters the world, the follicle becomes a corpus luteum if that egg does not get fertilized, which most of the time it doesn't. And we make lots of progesterone to then counter some of the proliferative action of estrogen, which, estrogen is growing everything, including our uterus, our endometrium, our, endometrial lining to catch and help that egg implant if it is fertilized. Progesterone kind of puts the stopper on some of that and stays the course until it's time to have a period and helps us to shed that lining at the end. So there's all this interplay between, an estrogen dominant time and then an estrogen time where progesterone is also on board, tempering down some of its actions, and everything has to happen perfectly in order for reproduction to occur.
That's a great summary. Thank you. And actually, when you said it has to happen perfectly, the more you learn about the menstrual cycle, like, don't you think, like, the more you know, the more amazing it is that anyone gets pregnant ever?
How does it even? I felt that way in microbiology too. Like, how are we alive?
Yeah,
everything can kill us. Everything's, but it does happen, and predictably so. And I think we know so much more about the menstrual cycle and all of the little inputs. We can delay follicle development till the perfect time, and then we can speed it up at the perfect time, and then we can make you ovulate at the perfect time, and then all of these things that we've learned how to do over time are really exciting, and they work pretty well.
Yeah, it's fascinating. So if a woman had lower estrogen than expected, what are some of the signs and symptoms that when you said, like, well, menstrual cycle irregularity, you mentioned already. So that's one, because of course, if it's, usually they get longer, right, with lower estrogen.
They do. They get longer with lower estrogen. And one kind of unexpected sign of low estrogen is that your periods last a really long time. Usually we think of like a 5-day period. Maybe you have a couple heavier days and, some spotty days at the end. People with low estrogen, like maybe they have a delayed follicle development and they're not developing follicles until maybe day 14. Those guys might have a longer period because, that signal that we're done with our period starts with the next developing follicles. So if you're not starting to get that little rise in estrogen, you might just bleed for 2 weeks.
That's so interesting. So it's really, do you see that, so that's really because of the delay with the start of the follicle. So they're not producing more estrogen, causing the lining to start to regrow, is what you're saying.
Yeah,
cool.
Exactly.
Very cool. So what else?
Yeah. So other symptoms, I always think of like dryness. It's dryness of mucous membrane. Some people have like dry eyes or dry mouth. And, obviously vaginal dryness is kind of a famous perimenopausal and menopausal symptom, but you can have that even in premenopause. But I also think of, the main one that I tend to see in my younger patients over the years has been like mood dysregulation. People feel kind of mild depression, I would say, can go along with low estrogens, really particularly. And I would say, like major depression is usually multifactorial, but that mild depression that seems to be kind of cyclical can go along with low estrogens or the drop in estrogen at the end of the cycle. And then, other low estrogen symptoms could be, things like joint pain. Often we'll see that with low estrogen. So in younger folks.
It's interesting because you're talking about these things that are like extra, like outside
Right.
the menstrual cycle.
Yeah.
The joints, even
Skin
cognitive stuff.
and
Yeah.
yeah, exactly.
Yeah. So interesting. Another thing that I think about is libido. What about libido?
Yeah. Yeah, I think it's multifactorial too. Libido, yes, it can go along with low estrogen, but usually it's low estrogen that's secondary to low androgens. And it's, you always want to back it up a step or do some testing and just see, is it low estrogen in a vacuum or is it low estrogen with low testosterone and low DHEA and adrenal function that's, wacky because you're dealing with stressors. And if you just give somebody estrogen with low libido, you might be disappointed with the response because it may not be the be all end all by itself.
Yeah, actually all the trials have been disappointing, and I think it just speaks to the fact that we are really complex beings,
individuals.
Women. We are complex individuals, and it's not as straightforward as like for men. Most men on testosterone feel a stronger libido, but it's not as straightforward with women, particularly because it's the response and the signaling to the brain and like the emotional cognitive connection is so different for women that you can have perfect hormones and still have low libido. And anyway, we need to do a separate podcast episode on that. I think
part of it is that, in male hormone replacement therapy, you're replacing a little further up the steroid pathways. And whenever you do that, you give the body the opportunity to make estrogen out of that testosterone, and they do, and it does support their bones, and it does. You're able to get more done with one therapy than if you're going in with estrogen replacement therapy on a female patient. That's great, but then there's still all this stuff upstream that estrogen's not going to back convert to testosterone or DHEA or,
Great.
You still have to pay attention to those things.
Totally. Yeah. So, you mentioned bones briefly, and I'm glad you brought that up because that was on my list of things I wanted to ask you about, which, when it comes to estrogen, there's some really important health promoting, jobs of estrogen in a cycling female, bones being the one that we talk about the most, right? So if a woman is in her cycling reproductive years, let's say she's, 20 and her estrogen is low for whatever reason, whether it's genetics or whether it's, like you said, exercise, undernutrition, what are some of the long-term health consequences that you think about that make this an important thing to address?
Yeah. I mean, but I would say bone loss is probably the number one thing. And, they've done studies on premenopausal women and those with, they're using serum to look at estradiol levels and make correlations with bone mineral density. And the cutoff is 60 for, you think about serum ranges, 60 isn't all that high into the luteal range. Actually, it kind of overlaps with the follicular range of estradiol in a cycling female. But if you're over 60 picograms per mil in serum for total estradiol, your bone mineral density is adequate, is higher than those with estradiol levels under 60. And if you think about what that would correlate to on like a Dutch test, think of like 2.4, between 2 and 2.4, I think of as like fairly comparable to 60 on a total estradiol LCMS test. So if you're, lower than 2, and our luteal range goes from 1.8 to 4.5. So it doesn't even have to be that high in the luteal range. But if you're hanging around there, but you're lower than 2, between 1.8 and 2, like I'm worried about your bones. And if you think about the things that we end up dying from in our lives, we break our hip, we lose our mobility, we perish. Or, what happens to our genital urinary systems. I mean, I haven't seen a really great study that said, you start to have genital urinary problems or atrophy or whatever under a certain number. Maybe it's 40, but in a premenopausal female. But I bet you if they did those studies, it would probably be right around there. So if we made under 60 and under 2, 2 in a urinary estradiol, make that your goal. And if somebody's under 2, we want to go after those types of low estrogens with the impact seen at the bones and the genital urinary system. You could make a huge difference in somebody's life probably as they get towards menopause. If we've been on top of this since you were 25, then maybe you're not going to be suffering from, in the hospital with complications from a urinary tract infection that eventually leads to your demise when you're 85 because of the work that you did when you were 30.
True prevention.
Yeah.
So
yeah.
You mentioned the Dutch test. Now, where can you look at estrogen levels on the Dutch test? What are the different elements that a provider or a patient should take a look at?
Yeah, I think, when you're looking at urine, you're looking at so many more elements than just estradiol, even though, Dutch has been really, really proactive about putting really good research out there on the correlation between urinary estradiol and serum estradiols. But it's almost a little on the side of, well, that's nice, but almost a little misleading because there's so much more to the urine story that adds to circulating estradiol levels. It adds what happened at the tissue when that estradiol was taken up. How are the tissues moving through that estrogen? Are there metabolites that we're making that are continuing to interact with estradiol receptors? And I mean, you just can't get that information from a total estradiol in the serum. It's impossible.
Okay.
You have to guess.
So you have me like completely salivating for what I want to cover right now because this is awesome. So, let's talk a little bit more about that. You have serum estradiol measurements, which of course are valid and add a lot of value. And what I'm hearing you say is they tell something different than urine measurements. And then I'm guessing you're moving on to metabolites, estrogen metabolites too, that you can measure in urine too. So can you tell us the story of like what's going on when you're measuring serum? What are you measuring? When you're measuring urine estradiol, what are you measuring? And when you're looking at metabolites, you talk about in the cell, out of the cell, what can be impacting. Help us break this down because this is probably not something that most of our listeners, even providers, know or use on a regular basis.
Yeah. Well, and serum is the gold standard. It's what we're all trained to use. And I think the important thing that I try to explain to patients and to providers when I'm talking to them is that, serum gives you what was produced and what has hit the circulation, and it's available to tissues. Like, it's available.
You can't see if you're listening and not watching. Allison just gave us jazz hands. Like, I'm here.
I'm here. Like, you can take me up. You can bring me to the nucleus. I can upregulate genes that control things. Like, it's potential energy, kind of potential energy. And I think where functional medicine has started asking questions for the last 40 or 50 years or more, since the 80s, since Jeff Bland.
Thanks, Dr.
Was
Bland.
like, right, like, how are we responding to these hormones? What's the receptor status? Are we bringing these things into the tissues? Are they actually turning on the genes that they're supposed to turn on? Are some tissues dysfunctional? Are we downregulating receptors and we're less responsive to this hormone? Those types of things. And then once things happen in the tissues and these hormones are breaking down, how are they breaking down? Are they just leaving and going to the trash can? Or do they turn into other things that maybe continue to have activity at the tissue level that maybe influences risk? Those are the types of things you're looking at in a urinary metabolite test. You're not only assessing, the free and bioavailable fraction, which is huge, high impact concept that we try to approximate when we're serum testing by looking at binding globulin levels. We try to guess how much free and bioavailable hormone is at the tissue level. But even those indices and even the direct free hormone measurements in serum are rife with problems, for accuracy and validity. So it's really, really hard if you're just relying on serum to figure out what the tissue impact of those hormones are. So that's why we like to look at urine, because we're able to look at, yes, those parent hormones, which is helpful, but we can also see how they turned into other things along their pathways to hit the trash. And we can analyze the ratios at which they're formed, which can tell us about enzyme activities, a little bit about your genetics, a little about things that are maybe impacting your epigenetics or how you're expressing those genes. And when we think about estrogen in particular, estradiol and estrone, when they're breaking down through phase 1 metabolism, there's one pathway that leads to kind of the anti-proliferative, anti-tumor, the good pathway, the CYP1A1 pathway, that we really want most of our estrogen to break down through. It is impacted by genetics, it's impacted by nutrition, so there are many things that we can do besides change your genes, maybe, that can impact that pathway activity. And then we have other, what we would consider the bad pathways that form metabolites that can initiate cancerous processes if we don't have genetics that help us to fix the DNA if it's damaged, or if we have SNPs in our glutathione pathways, or we have issues with quinone reductase. So there's lots of things that have to go wrong on the way for 4-hydroxy to cause cancer. But we want to put eyes on those 4-hydroxyestrogens. Do you make a lot of them? Do you make an unfair amount of them compared to the 2-hydroxys? That's really important information for risk and for maybe how somebody feels. Maybe they have fibroids, or they have endometriosis. We want to put eyes on some of those metabolites. And the 16-hydroxyestrone, that's another one we should probably talk about at some point, because it kind of circles back to the Goldilocks concept, where you don't want to have too much of it, because it can be like fuel on the fire for a proliferative situation like fibrocystic breasts or fibroids in the uterus. But if we don't have enough of it in menopause, it can lead to, or is correlated with, bone loss. So the way we metabolize estrogen really, really matters. And you don't get that information, I don't think, in the same way, in the same story line that you get in urine.
That's super helpful to kind of break down what the differences are. And really, they all can tell you something different.
Yeah.
And so it almost depends what types of questions you're asking. Now, when we look at urinary estrogen metabolites, phase 1 metabolites, phase 2, when you get to kind of a methylated form, if estrogen is low, are the risks and benefits as high when you have like less of it in total around in the body?
They're lower. So when you think about risk factors for, say, breast cancer or endometrial cancer, a lot of those risks come out of having elevated estrogens. That's kind of the number one thing. So if you don't have elevated estrogen, you could kind of tick that risk factor off of the list. So it's less impactful. That said, if you're thinking of putting somebody onto estrogen replacement therapy and they have a strong favor towards the 4-hydroxyestrogens, you might be mindful about that and layer in supports that downregulate CYP1B1 pathway expression. Those are always, really great foodie things that you can do. The citrus fruits, some neat studies that they've done on epigenetics and just food intake. People who ate oranges and every day tended to have less CYP1B1 activity and lower 4-hydroxyestrogens. And I think, that's such a powerful thing for people to know about when they're going on to therapies and they're wanting to do protective things, and they want to have a good experience on their hormone replacement therapy. and so do we. So
Great. So for a cycling female with low estrogen, what are some of the therapeutic things that you might think of? And you mentioned hormone replacement therapy.
sure.
That gets more complex probably in a cycling
Mm-hmm.
patient. We can talk more about peri and postmenopause afterward. But let's talk about cycling females first.
Yeah. Remove the obstacle, right? Identify and remove the obstacle. So if we're not eating enough, if we're over exercising, if our prolactin is too high, if if there is like a physical reason why we have suppression of the HPG axis, remove that obstacle to cycling, and usually we can get people going again. When estrogen is low because androgens are low, maybe you have adrenal output issues because we've had chronic stressors, chronic infections, chronic inflammation, chronic whatever, and we have HPA or adrenal axis dysfunction where cortisols are low, DHEA is low, precursor to testosterone and estrogens are low. Then it's about reestablishing all of those pathways. So we want to restore adrenal axis activity, HPA axis activity. We want to work to treat whatever chronic infections or chronic stressor that is stressing that system. Sometimes we'll layer in adaptogens, especially the androgen supporting adaptogens like tribulus and maca and shatavari, fenugreek, and all those wonderful smilax, or sarsaparilla is the other name for it. All really helpful for like really working and supporting the DHEA side of adrenal function, and kick that into gear. Sometimes we give some DHEA. Sometimes we give a lot of DHEA if people are trying to get pregnant actively. And the idea behind doing that is to stimulate the androgen side of follicle development, because those estrogens come from androgens, originally. That's where, if you think about the steroid pathway, the chicken wire steroid pathway chart that comes down from pregnenolone, cholesterol enters the mitochondria and star protein is upregulated by whatever stimulating hormone is asking for a particular hormone, and it upregulates that conversion of cholesterol to pregnenolone. And then all of those genes for the enzymes that bring that steroid pathway activity down to the hormone that we want, that hormone is spit out into the mix. We think about in the ovary, that's testosterone originally from the theca cells. And then we have aromatase of testosterone to estradiol. So we have to think about all of those moving parts. As a functional medicine clinician, we're working the adrenal edge for the DHEA, for the egg quality, and we're working on restoring any problems with signaling from FSH and LH from the pituitary to the ovary. A lot of times we're using herbs for that. Some of the phytoestrogens can be helpful, even some of the phytoprogestogens like Vitex or chase tree berry. So there's some really wonderful things that we have in our arsenal to turn on the lights in the factory, I like to say.
I love that.
But you got to work both edges.
Does mitochondrial health play a role in any way?
Huge.
Okay.
Huge. And that's why, patients who are working on their fertility or have been working on their fertility for a long time before they come to see you often will come to you on a lot of these types of supports, and they read about them in articles and studies and on fertility specialist websites. But time and again, the mitochondrial supports are study well for increasing our follicle development. Essentially, when you layer in CoQ10 and vitamin E, let's say, just like really basic mitochondrial support, especially during the follicular phase while the follicle is developing, you're improving all of that hormone production early on in the cycle so that you get this really strong, ready follicle and egg complex. By the time it's time to ovulate, that's going to just give you a beautiful luteal phase after that, because you're kind of resting a little bit on your laurels of what you developed in the follicular phase once you get to luteal. So if you have a really strongly developed follicle by the time you get to day 14, I mean, your luteal phase is going to be really balanced with progesterone and estradiol, hopefully.
Yeah, I talk about that with patients a lot too. I kind of, in my attempt to simplify, I'm like, your progesterone's made by the corpus luteum, which is basically a transformed eggshell, so
Yeah.
the
Yeah.
quality of the egg and the quality of the eggshell drive how much progesterone is made. And I try to teach that to providers too, because a lot of times when progesterone's low, we love progesterone in functional
Yeah.
medicine. We love giving progesterone, topical progesterone, oral progesterone, but we don't always think about low progesterone, which is not the topic of this podcast. So we're getting off track,
Right.
but let's wrap this up anyway. Like, we don't always think about low progesterone as a sign of a problem, which
You
the
can't talk
problem,
about estrogen without
you're right.
progesterone.
It's like your best friend not being able
Yeah,
to come along to the party.
exactly.
It's really low progesterone is a sign of poor health of the corpus luteum typically. And you're getting
Exactly.
underproduction or production for not 14 full days. You get spotting at the end of your cycle or before your period starts, things like that. Normally, you have to look at mitochondrial health, oxidative stress levels, follicular development, and estrogen priming in the first half of this
You hit
cycle.
it on both
Hit it
sides.
on
I
both
think
sides.
sometimes we make the mistake of just going after it in the late luteal, and that's a nice bridge therapy while you're working on the follicular phase and the mitochondrial health and the androgens and all of those things that build those follicles at the very beginning. It's not to say you can't start some luteal progesterone in the last week of the cycle. That's great. That's going to make you feel so much better. But we want you to do it on your own.
Yeah, I totally
At
agree.
some point.
Totally agree.
Yeah,
We got to start at the beginning of the cycle.
that's right.
Okay, so we've talked about low estrogen in cycling females, and you've given some really great suggestions on how that can be really supported from a multifactorial perspective. So I'm really grateful for that. Now I want to shift to menopause, and even more the time in between cycling and true menopause, where we start to see all this hormonal fluctuation. So can you tell us a little bit about the wacky wild estrogen roller coaster between cycling female and menopause?
Yeah. Yeah. Well, and it's a little different for everyone. Like, I'm in the perimenopausal transition right now, and my archetype, if that is a thing, is that I have really, really high estrogens and really, really high androgens and really, really high progesterone. Like all the volume is turned way up, and it's all the time because I do my cycle map. Like if you work here, you get to do testing on yourself
It's such a
a
nice
couple times a
benefit.
year.
It's
So I have
fabulous.
lots of tests on myself. And I'm always this. It's not like I ever get a break from my high estrogen. Even early in the follicular phase, my estrogen is high. It's like luteal high.
Cool. Crazy.
So, like, maybe I'm your poster child for breast cancer risk. I don't know. It doesn't really run in my family. I don't know. We'll see. But the idea in perimenopause is that FSH and LH are rising as your ovarian reserve is dwindling to some degree. We become less and less responsive to those FSH and LH signals to develop follicles and ovulate. And when we do develop follicles and ovulate, depending on our other stress load in the system, we may or may not ovulate once we develop a follicle. So we might be all estrogen and not ovulate, or maybe we ovulate but the progesterone's really low the entire luteal phase. And so we become essentially estrogen dominant, some form of estrogen dominant in perimenopause. Whether our estrogens are high or low, it's that sort of lack of progesterone that leads to symptoms. And you have phases of perimenopause too. You might be cycling normally, but maybe with some higher estrogens in the early perimenopausal transition. And then you might, towards the late perimenopause, really kind of settle down into pretty low estrogens along with low progesterone. So it really just kind of depends on where you are. And then in that middle of perimenopause, it really can be cycle to cycle really different. So I think we like to test during perimenopause because we want to get a sense of where in the perimenopausal transition you are. You could be 46 and be in late perimenopause. You could also be 46 and not even entered perimenopause.
Mm-hmm.
Like it really is that different from person to person. And I think perimenopause, the symptom picture is that of low estrogen, even if your estrogen is high when you test it. Because of that variability, you're going to be working to control other factors that temper estrogen swings down. That's when we start talking about progesterone and we start talking about androgen supports and all of those things that make us feel normal when we're going through perimenopause are the things that temper estrogen swings down.
Fabulous. And now let's shift into menopause. Of course, menopause is kind of hallmarked as a low estrogen state. So,
Yeah.
what are some of the main considerations that might be different from what we've talked about so far?
Yeah. Well, I think, in menopause, once your estrogen levels kind of settle down to a norm, it doesn't necessarily mean that it feels good. People have hot flashes and night sweats and vaginal dryness and bone loss and joint pain, and they have all of these things for the first time. Sleep problems. Sleep is a big menopausal symptom that I wish would be recognized immediately as a menopausal symptom when people come in the door. It just is maddening, I think. You have somebody who's been relatively healthy, well, their entire lives, and then they're 53 and they come in and they say, I need something for sleep because I'm desperate to sleep and I can't. And then we're doing or they're coming with Zolpidem and, all of these sleep meds or trazodone, and just thinking, why didn't they just give you some estrogen? Like, what are we doing here? Like, we're just band-aiding all these little things, and they're on an SSRI, and they're on, there's this constellation of things that happen when we're early menopausal that should be sign that, maybe it's time to think about estrogen replacement so that your brain can stay happy, your bones can stay happy, your genitourinary system can stay happy, and, maybe even your cardiovascular system for how estrogen plays into mitochondrial health there too. And it's not always thought of, ironically, first.
Well, I think we're still dealing with the effects of WHI, which was published about 15 to 20 years ago, but really connected hormone replacement therapy with risk and risk of harm. It scared a lot of even physicians off that it haven't really updated their understanding since more research has been published. And I think, our point of view at Dutch on that, because I think people ask about this all the time, rightfully so, is that it needs to be an individual choice. HRT and estrogen replacement therapy menopausally is not the right thing for everyone. And for some women, it's not necessary. They feel good, and there's not, you might think about it for bone protection or some of cardiovascular protection, or there's some early studies now suggesting cognitive protection or support.
Yeah,
but those aren't FDA approved indications other than bone protection, and we're not there yet on data to be able to say it. And so and there is risk involved still, so it has to be weighed. We don't believe it's a blanket therapy
but
for everyone.
About as much risk as a glass of wine in the evenings. Well, when I graduated from medical school, the recommendation was Mediterranean style diet. A female should have a glass of red wine every day, and a male too. That's healthy for your cardiovascular system. And it's so interesting that the Women's Health Initiative found some of these risks are essentially less than the one glass of wine. You know what I mean?
Totally.
Wow, what a paradigm shift. And let that be a lesson to us.
I'll never forget when The Blue Zones came out by Dan Buettner, that book. And I read his book and I loved it. It was fabulous. I would recommend even still looking at it now because it's really fascinating research. But they had a quiz at AARP's website that you could do to see what you should be working on in your life. And the one that it told me was I should be drinking more.
I should be drinking more. Yeah.
That was my only factor that I should modify, is I should be drinking more. I'm like, oh, that's so funny. And now
I
things
think
have
it's
swung.
So healthy for us all to understand that we're walking through this world with baked in risks. There's baked in risks
Absolutely.
in everything, breathing air. And, if we want to we really want to boil everything down to probability and numbers per 10,000 people, which is what medicine wants to do, because, you're a number in a group, then, we can do that. And the perspective is that the risk for estrogen replacement is actually really low. And what's cool is that a lot of the CE medical education outfits like Medscape, a lot of us will subscribe to like a digest because there's so much research that comes out every single day.
Mm-hmm.
And, Medscape, it's all over Medscape, the recent article coming out on, hey, how do you digest this information? What are the contraindications to hormone replacement therapy now that some of this new, reappraisal of the Women's Health Initiative has come out and the new NAMS guidelines have come out? And, maybe there aren't any absolute contraindications to hormone replacement therapy. And that's insane.
That would be, I mean, that's not where we're at right now, but it
Well,
could be, we could be there.
There are
potentially.
relative contraindications,
Relative,
right?
yes.
Obviously, but there are no absolute ones, which is really fascinating to me because that was not the language.
Yeah, you're absolutely right. But there's such a quality of life. One, I think quality of life improvements matter for women. And I'm glad to see that societally we're accepting that. I know there's been this big, difference in insurance coverage and accessibility and affordability of, let's call them like lifestyle drugs for men, right? That are easy to access, but not the same for women, even with things like hormone replacement. Glad to see those things changing. So that's number one. And secondarily is when you are considering hormone replacement versus an alternative, like you'd mentioned, heavy hitting like benzos or sleep medications or SSRIs, which also carry risk. When you're looking at, of course, something like SSRI is prescribed for mood changes. Hormone replacement therapy is not FDA approved for mood changes. However, it's, I would say, commonly used off label to address like mood instability in postmenopausal females.
As long as you have another,
if you have another,
some hot flashes
too.
and
hot flashes and, vaginal dryness. My point being, when we look at the totality of options available to females, oftentimes that's the lowest risk intervention that you could try first when you look at all the symptoms that are going on. So grateful that we are understanding it better. And,
me too.
I'm grateful we have a army of well-educated OB-GYNs, naturopathic doctors, functional docs, etc. who are.
It's hard to always be ahead of the curve.
Well, this has been awesome. I'm really grateful for your time. I think it's so helpful.
Thanks for having me.
We talk about estrogen dominance all the time. And I think it's really helpful. One, you did explain that concept that it's not always overproduction of estrogen. And that's not even a medical term, but it's about the relative relationship. But talking about low estrogen, because this does impact a lot of cycling females even. And then when we get into peri and postmenopause, it becomes a really important factor for most women to be thinking about. So thank you, Dr. Allison, for your time today. It's been great to chat with you.
It's been really fun. Thanks for having me.
If you're wanting to learn and really expand your expertise in hormones, you're not going to want to miss our podcast. So make sure you tune in each and every week for our new content.